When it's the shin, for in-towing, it's internal tibial torsion. Also a packaging defect. This is the most common cause of in-towing in kids who are less than 3 years old. So this is most often what's going to be going on when a parent brings in a toddler and says, my kid is pigeon-toed. It's been there all along, but parents usually don't notice it until the kid starts to work. So to examine for that, what you do is you have the kid lie on his or her belly on the table, and you flex the knees up to 90 degrees, like this, okay? And you take that heel bisector line that you've already drawn on their ankle, or on their heel, to see if that's metatarsus adductus, and you compare that with the angle of their thigh, okay? And a normal angle is either that heel bisector line matches up with the line of the center of the thigh, or it's slightly positive, okay? Meaning they are out-toeing just a little bit, okay? If it's negative, okay, meaning if the heel is going this way, then it's internal tibial torsion. So if it's angled up this way by more than negative 20 degrees, that's internal tibial torsion. Does that make sense? Okay. All right. The other thing that you can do is actually check the lateral malleolus, which should be posterior to the medial malleolus. And if it's not, if it's even, that's a sign that there's internal tibial torsion. Okay. So treating this, a lot of times, if you ask, parents will say their kids sit like this frequently. They just kneel down a lot. So if you encourage them to sit cross-legged instead, that will help it correct a little bit faster. Otherwise, just having him walk, it will correct with age. Okay. When it's higher up, when it's the thigh, it's medial femoral torsion or femoral anteversion. And this is the most common cause of in-towing in kids who are older than 3 years of age. Okay. So same thing, you get the kid lying flat on their belly like this, and now what you do is you just flop their legs in and you flop their legs out. Okay. And normally a kid should go 45 degrees in either direction. So about there, all right? If they can go, if they can internally rotate, so if they can go like that, yeah, which a lot of kids can do, that is femoral anteversion, okay? So normally they should be able to go here. The kid can go there. That's femoral anteversion, and that's why they're in-towing, okay? And a lot of kids who have this will sit in that position normally. So they'll sit in what's called the W position, like this. Yeah, which to a grown-up doesn't look very comfortable at all. Okay? So instruct mom and dad to say, hey, when you see your kids sitting like that at home, say, no, you gotta sit, cross-legged. And then that will correct as well, but it happens a little more slowly. So kids probably won't occur this until like 4th or 5th grade. Okay? Alright, so in summary, if you have a parent bring a kid in for possible in-towing, watch them walk to see if they actually are pointing their toes in or out, okay? Then look at the bottom of the foot, draw the heel bisector line. If that's normal, have them lay down, and you're going to check the shin by checking the heel bisector line against the line of the thigh, and then you're going to flop their legs in and out. And you're going to see how flexible they are in either direction. And that will tell you where the in-towing is originating. Does that make sense? Questions? Okay. All right, I'm going to talk about out-towing too. Okay. So parents will commonly come in and say, my kid's duck-footed, his toes are pointing out. There's only 2 causes of out-towing, and it's far less common than in-towing is. So external tibial torsion and then femoral retrograde instead of femoral anteversion. So in external tibial torsion, the thigh-foot angle is positive. So remember, this is normal, okay? If their foot goes like this, when you have their knee flexed, meaning the angle between the heel bisector line here and the line of the thigh there is more than 20 degrees positive, then that is external tibial torsion. Okay? And then to go all the way like this, but they can trigger all the way like that.
Are they restricted in going the other way?
Not necessarily.
Okay.
Usually, yeah. Usually they'll be kind of normal here to just that 45-degree angle, but they can definitely get some angle force there. Okay.
So if curved on their own, how long do you wait?
Well, you actually hardly ever need to refer to ortho for internal or external tibial torsion or for femoral anteversion or femoral retroversion. The only time you would refer to ortho would be if you've got a rigid metatarsus adductus. Okay, so the answer is never. You can handle this. Okay. The only time that you would for external tibial torsion would be if it's only one side and if it's persistent, probably beyond 5, 6, 7, 8 years of age. Okay, or if it's causing the kid extreme amounts of pain. And what they do is they actually drill holes into the tibia so that they can twist it, and screw it, and correct it. So it's not fun surgery. It's not something ortho ever just like. So they have to be fixed. Okay, so that in towing and out towing, you guys can handle it in your office. And then this is just a diagram that shows the normal range when you're checking for internal and external hip rotation, and then that draws out the 5-foot needle. And then other things to think about, and again, you're going to be seeing this when you watch them walk, but remember, if the kid is knock-kneed or if they're bow-legged, that's going to kind of naturally cause some in-towing and out-towing as well. So look at, you're going to see that when they're walking. Make sure that it's not, that they've got geniferum or genivalvum. Oh, and then the other thing, the other common thing that parents will notice is you'll hear one of a couple different things. Parents will come in and say, my kid has weak ankles, or I think my kid might be knock-kneed because when they stand up straight, they kind of do this. And what you'll find is that actually they have a flexible flat foot, which means when they're sitting on your exam table, they've got a normal arch. And then when they stand up, they actually hyperpronate their ankles, so their ankles, sorry, I've got boots on today, their ankles roll in and their arch disappears. And that's actually congenital. Some kids will outgrow it, some won't. Professional athletes have this, so you can reassure mom and dad, your kid can still go to Notre Dame and play basketball. It's not a big deal. They'll be fine. Bottom shoes with good arch. Questions? Okay. Yes?
What about toe walking?
What about it?
I don't know, how do you evaluate that? Is there, you need to refer that to ortho?
So it depends on why you think they're doing it. No, you don't need to, you really don't ever need to refer those kids to ortho. So sometimes it's a stress reaction. Sometimes it's a developmental thing. Other times it can actually be like a tight Achilles tendon or a tight gastrocnemius. And so what you can do is you can actually refer those kids if it's significant or they're not outgrowing it or it's a major concern to mom, dad, or the kid. You can refer them to either a child physical therapist or occupational therapist who can prescribe some stretches, and it's just simple calf stretches. Do some therapy in the office or even prescribe some braces or some special orthotics that can help them to walk. But most of the time, reassurance is really all that can do. Does anyone have any other experiences with toe walking? Where to next?
Common disorder.
Okay. All right, so this was our full-term little girl